Evening, everyone. Welcome to our bi-weekly scientific webinar on topics related to lung transplant. I'm Dr. Balasubramoniam. I'm the director of Heart and Lung Transplant Program at Yashoda Hospital in Hyderabad. Very happy to see Andre and Three landing beautiful on the moon. So it's a great day for all of us in India, and a special congrats to all our scientists who helped us to achieve us landing on the moon. So soon we may be seeing tours to moon soon, hopefully in our lifetime. So we will be talking about another challenging topic here, lung transplant, and we also aim to take transplantation to heights in our country. So the topic today is pre-transplant workup prior to a transplant. What are the challenges and the insights? Now we have three eminent speakers today. Our first speaker is Dr. Pradeep Dabhi. He will be he is a interventional lung transplant physician from KD Hospital and Sparsh Chest Disease Center in Ahmedabad, and he will be talking to us about the role of pre-transplant workup in lung transplant. Please go ahead, Dr. Pradeep.
Thank you, sir. Thank you. Am I audible to you?
Yeah, yes, you are audible. Please go ahead.
Okay, and my slide is well visible there?
No, we are not able to see your slides as of now. You may have to share your screen, please.
Yeah, now I think it's visible.
Yes.
Okay.
Can you make it full screen?
Full screen? Yeah, 1 minute. Just 1 second. Yeah. Now is it visible?
Yes, we are able to see it now.
Okay. Thank you very much, Dr. Vimi and team. It is a great honor to speak you in front of the leading lung transplant program from India. And we are also currently running the transplant program here in our hospital, and currently we did around 3-4 transplants. So it's a beginning for us. Today we are speaking of pre-testing. So why a lung transplant candidate or recipient needed this type of testing, which is very important before we refer the patient for a lung transplantation, whether the patient is fit to go ahead for the transplant. So which is very, very important scenario. So as we all know, lung transplantation is immensely complicated endeavor for the recipient to undergo. And for the transplant team, there is a lot of challenges to manage. So careful selection of the recipient, their timing of referral, timing of listing, all is very, very important for great outcome of the patient. And the science of survival after a successful lung transplant is still a leg far behind for compared to other solid organ transplant. So we have to carefully select the patient. We have to see all the parameters, recipient characteristic, donor characteristic, surgical approach, medical management, everything is very, very important. So, and we all talk about the window for the lung transplantation. So it is to be said that patient is sick enough to need a transplant while being well enough to undergo the transplant. So which is very, very important. And we need to keep in mind post-transplant complication, especially early post-transplant period. So before selecting the recipient, some are the modifiable risk factor we can correct before listing the patient or even after listing the patient, like BMI. We can improve the patient exercise capacity, social situation, while others are non-modifiable, like non-pulmonary organ dysfunction, prior malignancy, chronic infections. These are absolute contraindication for lung transplantation. So before we move, we should know where not to do the lung transplantation. So the listing start from here onwards. So if somebody is not willing, somebody having active malignancy with a recent recurrence, kidney disease, liver disease, heart disease, brain disease. So there are a crux of this organ abnormality. So anybody have EGFR of more less than 40, patient who is on dialysis, acute coronary syndrome in less than 30 days, stroke in less than 30 days, active liver disease, active infection like patient who is on septic shock, active tuberculosis infection, HIV infection with detectable viral load, patient who is not willing to undergo lung transplantation because of poor rehabilitation potential, severe uncontrolled medical condition which is expected to limit survival after transplant. So if you keep this thing in your mind, the listing, the evaluation becomes very easy. So evaluation testing, so depends on this contraindication, the evaluation testing will goes on. So for first and foremost important is lung assessment. So we do X-ray, full pulmonary function test, ABG, 6-minute walk test, HRCT. So based on that, we assess the lung, whether the lung is a good, function is good, patients, how is the ILD, how is the COPD, we can assess based on this functional abnormality. Then we assess the heart. Heart is very, very important to decide whether the patient is go ahead with the bilateral lung transplantation or he may need a heart transplantation. So heart we have to thoroughly and absolutely we have to measure all the parameters. So first and foremost is ECG, echo, right heart catheterization. We have today a cardiologist in our team to speak on that. Left heart catheterization, which is CAG, is very, very important before doing a transplantation, especially when the patient is more than 40-45 years. And this assessment like carotid artery assessment, Doppler study of both the lower limbs, which is very important for as much as the heart is concerned. Then we have a GI evaluation, which is very, very important because as we all know, most of the fibrosis patient, the new theory is the chronic microaspiration. So somebody has GERD, somebody has esophageal dysmotility, somebody has a hiatus hernia. So which is very important to assess based on pH manometry, impedance test, upper GI endoscopy. Nowadays, a new thought of colonoscopy, as we all know, which is a routine to perform in all solid organ transplant. The prevalence of post lung transplant, PTLD, lung transplant, lymphoproliferative disease and malignancy is very high. Particularly colon cancer is very high in all solid organ transplants. So colonoscopy is now a routinely recommended test before performing the transplant. DEXA scan to assess the bone function and everything. Cancer screening, as we all know, which is very important. So prostate specific antigen in male patient and pap smear and mammogram in female patient. Colonoscopy, as we all know, is very important. Then the laboratory workup, which all laboratory marker is required. So all comprehensive metabolic profile is very important. CBC, liver function, kidney function, vitamins, HB1AC, urine analysis, blood group and typing based on which we can take the lung. Then virology is very important, as we all know, as all the hepatitis workup, HIV, then CMV, serology and EBV and toxoplasma is important to us because post-transplant period, all patient needs a prophylaxis against this infection. So whether IgG or IgM is positive or not. Then we have HLA testing, which is very important. For the cadaveric transplant, the ischemic time for lung transplantation is very less. So we are not matching HLA matched donor, but we will treat post-operatively, depends on their HLA analysis. So which is also a strongest indicator. Then we have a consultation, all the referrals, cardiology, cardiothoracic surgery, gastroenterologist, transplant nurse coordinator, social worker, and psychology. Psychology is very, very important because patient has to undergo a long hour surgery, then impact of ICU, then patient has to stay in hospital for at least 20-30 days. So there is a lot of stress in patient's life. So we have to counsel the patient, and psychiatric consultation is must before going such a complicated surgery. So that's it about my presentation. This is just a narration of why pre-transplantation is important and which all tests patient has to undergo before transplantation. Thank you.
So Thank you, Dr. Pradeep, for the speedy elucidation of what are the tests we do in pre-transplant workup. Now, he has, as you rightly said, the recipient selection, the timing of referral listing is pretty crucial, and we need to find that exact window period where we can actually go in and do a transplant. Now, you were mentioning about malignancies being an exception, being a contraindication. But are there some malignancies that we feel can be, are there exceptions where we can consider them?
Yes, yes. Yeah, definitely, sir.
Can you elaborate on which are the malignancies that we can actually consider? Some malignancies like skin malignancies where we have recommendations. If they have no recurrence in 2 years, we can go ahead and offer them a transplant.
Yes.
And we do see new recommendations coming up for lung transplantation for oncoalveolar carcinoma.
Bronchoalveolar carcinoma, yes, sir.
It's a new area that's coming in up. Two words about, I want to ask you about the cross matching before you choose your donor. So what are the immunological tests that you do once you identify your donor?
So we do panel reactive antigens and HLA testing for donor and recipients. But the matching is very difficult at the time of operation. So after the operations, we see what are the antibodies is positive. If it is DQ type of and titer is say 1 in 1000 MFI unit, then we have two options. Basically, we need to clear that antibody from the recipients. We can do a plasmapheresis or IVIG or something like that, and we can control that after 3 to 6 weeks if patient is stable. So which is very, very important as far as the lung transplantation is concerned.
Okay, so do you do any virtual cross match or CDC once you have identified your donor?
Yes, definitely we are doing.
Okay. So we'll go on to our second topic of the day, the role of right heart catheterization in lung transplant. And we have a speaker, Dr. Aditya, who is a consultant interventional cardiologist at Yashoda Hospitals, Secunderabad. And over to you, Aditya.
Sir, can you see the slides, sir? Are you able to see the slides?
Yeah, we are able to see. You can make it full screen now.
Yes, 1 second. Is it full screen, sir? Full screen now?
Yes, sir.
Yes, it's
yeah. So first of all, sir, thank you very much, Balasubramoniam sir and Vimi, for giving me this opportunity. I mean, I'm sitting amongst some of the best transplant groups in the country. I'm indeed proud of being associated with them. So the topic given to me is the right heart catheterization in lung transplant. So, sir, actually, I will just like to introduce myself. I mean, I did my DM from NIMS. So we used to get a lot of these children to do the cath studies, actually. I mean, those days, the surgeries were not, sort of scheduled. So the pediatric, lot of wait list used to be there. A lot of these kids used to go into these Eisenmenger or that partially severe PH cases, and I would be asked to assess them for reversibility and all. So I used to do lots of these CATs, oximetry runs and all. Some of them were little unscientific also, I must say. But a lot of times the call used to be taken on, when we mix up many things. As a cardiologist, we see the heart disease from multiple angles. The echo itself, then the CAT study, the values, the X-rays, and then we mix up and we used to take a decision. So even in this context also, why I just was reminded of this was, the right heart cath is still the gold standard for assessing the pulmonary artery pressures, the filling pressures, the cardiac output and all. But then there are several pitfalls, and probably we should learn to interpret them in the light of the pitfalls. And echo will be taking an increasing role in the future, and probably cardiac MRI as well. So with this background, sir, I would, my own understanding of lung transplant, I would like to convey, because I'm not really that kind of an expert in this. So according to me, lung transplant, contrary to cardiac transplant, it's actually a diverse group of disease. I mean, so many entities are there. And then it is a very indicated therapy for patients where we expect a reasonable survival. And the most common indications that I've seen in the recent where I've evaluated them was ILD, COPD, cystic fibrosis, and increasingly, in fact, I keep referring these cases of pulmonary artery hypertension for lung transplant evaluation. And others in a small group, of course, as a cardiologist, I'll be interested is the Eisenmenger syndrome and the adult congenital heart disease. If somebody has undergone a Fontan or something, Fontan failures and all. The important thing is the risk stratification, the assessment of mortality without transplant and post-transplant survival. I mean, this seems to be the key buzzword now. How do we put them on a wait list and how do we escalate them? The assessment of cardiopulmonary hemodynamics at the center of transplant is at the center of transplant evaluation. There's the cardiac output, the pulmonary hypertension, the shunt quantification, the cardiac filling pressures, etc. And then the etiology, the hemodynamics also seem to affect the therapeutic strategy, whether a person will go for a single lung transplant or a both lung transplant, or whether he will go for a heart lung transplant is some of the issues that I've seen come up. So this is the latest stratification. I'm sure you're all aware of this. Just from a cardiac point of view, I thought one interesting point in the waitlist urgency measure is the pulmonary artery systolic pressure. So this seems to predict the prognosis of patients once the PAH has set in. So that seems to be one important parameter where pulmonary artery pressure is important. The second is the group B. So when we are using the waitlist urgency and when we are adding up the score, the group B would be at a higher risk level. So this is where the pulmonary hypertension assessment becomes very important. So like even otherwise, idiopathic pulmonary artery hypertension is emerging as an increasing subgroup of patients requiring lung transplant. Reliable estimation of PA pressures, cardiac filling pressures, right atrial pressure, vasoreactivity testing, drug response. If you look at the timeline of an IPAH patient, they will go through several phases. And especially with the triple drug therapy and multiple drug options available now, they go through a journey. Now, once they become refractory to therapies, then the consideration for transplant would come. Other than that, even in other cases of say ILD or COPD, in those cases also, we see that because of lung destruction, the pulmonary artery pressures will continue to rise. Now, their prognosis or their their course of illness or their outcomes post transplant also seem to be affected by a mean pulmonary artery pressure more than 30 mmHg. Why I'm bringing in all this data is the estimation of pulmonary artery pressure seems to be at the center of lung transplant outcomes, or at least it seems to play a significant role. So both the pre-capillary and post-capillary hypertension are associated with higher 30-day adverse events post-lung transplant. So, like I said, gold standard is the right heart catheterization, but echo indices also are emerging. Now, there are some centers, I believe, pulmonologists are also doing right heart cath, and it's a good input. And one thing is, as a cardiologist, we are used to doing the left heart cath. Sometimes when the values don't add up, I mean, we find a very high wedge pressure or we find an abnormal value. What we do is when in our practice, we would actually bring in. I would go to the left heart. I would do a left heart cath, and then I would do a just check the EDP with the wedge, and then I say, okay, it's correlating or not correlating. So that is how we approach from the cardiology point of view. We have the advantage of doing the left heart cath also. So this is basically the classification of pulmonary artery hypertension. I will not go too deeply into it. Only the post-capillary, the pre-capillary, then now we have this unique group of people who seem to have both, a mixed pre-capillary and post-capillary pulmonary artery hypertension. Again, all this classification would require a good right heart cath study. So that would allow us to categorize the patient into an appropriate group, deliver the requisite therapies, and also which would also help us to prognosticate these patients post lung transplant. So again, the REVEAL 2 score, that is for idiopathic pulmonary artery hypertension. Again, here again, if you see, all the values that are determined by right heart cath are the mean right atrial pressure of more than 20. Then we can see this again can be determined with right heart cath only. The PVR assessment again we can determine with the right heart cath only. And then, of course, they have incorporated additional things, GFR and all. As whenever the score is above 7, these patients are recommended to be referred, and above 10, they are recommended to be listed. So again, here also right heart cath would play an important role. Again, the survival curves of different lung transplant patients are different, and idiopathic PH do particularly worse compared to other groups. The cystic fibrosis group seems to do well in terms of survival. Just a brief history. I mean, Werner Frostman, actually, he had taken a ureteral catheter, put it in his brachial vein, and taken an X-ray and found that it actually reaches the heart. It started, the journey started like this. And then the more real-world catheterization was done by Schwann and Gans. So in 1970, and they all went on to receive Nobel Prize for their efforts. So again, the right heart cath, we define our indications, the contraindication, the equipment we arrange, what kind of, then the pitfalls during, I mean, how do we zero the machine? How do we calibrate our things? I'll just give a short view, but this is the right heart cath basics. So this is a Swan-Ganz catheter. Now I'm sure everyone has seen this. Only thing what I wanted to mention was there are many reiterations of this Swan-Ganz from the very basic one. So we have the thermistor here, and we have the proximal port to inject the warm saline, or the cold saline. Then the yellow one is in communication with the distal tip. The white one allows us to give us some infusions, or it's in the RA. And this is the balloon inflation. And I think there's another thing that also allows one for a temporary pacing also. So there are many variants of these Swan-Ganz catheters. So again, simple flotation principle. We go from the femoral route because that's what we usually cannulate. So I prefer to do a radial angio and radial coronary angio and a femoral vein. That sort of thing I do. But of course, I think pulmonologists would prefer a jugular approach. Again, once we are in the right atrium, we inflate the balloon, and then the flotation principle allows it to float into the. So even in our pediatric caths, we used to have this Berman catheter, which also is some sort of a flotation catheter. So that also allows us to give an injection, ventriculogram also. So one thing I wanted to say was the zone of wedging, the zone 3, that this is the zone, the lowest zone, which is actually not affected by the alveolar pressures. The upper 2 zones are affected by the alveolar pressures. So we would prefer to wedge the catheter at this zone. That is one thing, is an essential point. Then the effect of respiration. A lot of your patients have this high peep, auto peeps and all, the wedge would be swinging from one end to another. If you want to get a reliable trace of the wedge pressures, some authorities have suggested to take the end expiratory value. Some authorities have suggested to take the electronic mean that is generated. But I prefer to go with the end expiratory value for all my measurements, for whether it's the RA, whether the wedge, or whether it is the everything I take in the end expiratory. That is one thing. So this is the fast flush technique to calibrate our catheters. You see, some catheters may be over damped or under damped. See, the problem is when we are doing these measurements, these are millimeters, 2 or 3 millimeters or 4 millimeters can make a huge difference in the calculation. So if your catheters are over damped, you may get damped values, and if your catheters are under damped, you may get wide fluctuations. This is a fast flush technique. You just flush fast, and then if the moment you see how many cycles it returns back to the baseline. So 1 or 2 cycles, if it returns, it's a correctly damped catheter. If it is oscillating more, it suggests an over damped. Less, it suggests over damped catheter. It suggests more, it's an under damped catheter. Then the other thing is the zeroing. So where we check this phlebostatic level, that's a very important determinant. A lot of technicians don't understand this. We have to set that point where usually in the sagittal plane at the 4th intercostal space, and in the center, and in the height wise, it should be between the sternum, between the spine and the sternum. So that point is where, because that corresponds to the LA. So if you put your catheter above or below, we are likely to get wide variation in the values. Then the pressure tracings. We should get good quality pressure tracing. We should be able to see all the waveforms very, suppose in the pulmonary artery, we should be able to see the dicrotic notch that tells us the catheter is, we are recording the true pulmonary artery pressure. And then the wedge pressure should show all the tracings, the A wave, V wave. Now the pulmonary capillary wedge and the LA trace, if you see, they're almost the same, except that the PCWP is slightly damped, slightly the amplitudes are less, and the time is little late compared to the LA pressure. That is one thing. The second thing is that the traces, for example, we are measuring the atrial pressure. We should measure it at the end diastole. So that is at the end of the A wave. So again, sometimes it may not be possible. So we just go by the end of the QRS. Sometimes a stable rhythm is required. The patient may be having a lot of VPCs and all. Then it may be difficult, but then we have to maybe take an average of these values and get an appropriate value. So the interpretation is something that we have to pay attention to. Then the calculations. The FIC principle is measures the arteriovenous difference of oxygen content. So then the oxygen consumption divided by the AV difference in the systemic side and the pulmonic side. And then we get the QP and QS. And if you want to quantitate the shunt, suppose we are evaluating a congenital heart disease, we actually go by this formula, I mean the QP by QS. Then the systemic vascular resistance, the cardiac output divided by the the mean pulmonary artery pressure. So again, the determination of PVR and SVR, like I said, every value that we initially have determined will play a role, very important role in the calculations. So even if you get a variation by few millimeters, we may see a wide swing in these values. So these are the typical normal values. So in terms of, because I was also evaluating this heart transplant patients, for them this transpulmonary gradient would be an important parameter. Anything above 15, the surgeon would be very reluctant to take up for isolated cardiac transplant. Between 12 and 15 would be the gray zone, and 12 less than 12 would be an ideal zone. Again, the diastolic pulmonary, the transpulmonary gradient is actually one of the important things that they look for the heart transplant. In the diastolic pulmonary gradient is nothing but PADP minus the pulmonary artery wedge. Again, like I said, it helps us to differentiate those combined pulmonary artery patients, I mean pre and post capillary combined patients with the exclusive patients, with only post capillary patients. So these are all the values that we calculate and we give to the operators. One of the important elements of right heart testing is vasoreactivity testing. The most reliable and most documented way is nitric oxide inhalation. Actually, we didn't have an opportunity to do this at our center, but other agents are available like adenosine. We can give. So this again we should incorporate in our because some of these patients who are severely hypertensive may actually respond to calcium channel blockade therapy. Again, the success of therapy is when you see a drop of pulmonary mean pulmonary artery pressure by more than 10 millimeters of mercury, we are encouraged to treat these patients with CCBs. Echocardiography is taking an increasing role because all these parameters which I've said, the RV systolic pressure, the RA pressure, we have ways of determining these values. Like we have seen the IVC diameter would correspond some way to the RA pressure. The RV systolic pressure, the tricuspid regurgitant velocity corresponds to the RV systolic pressure. Again, we have ways of doing it and quite reliably. Of course, we need to understand that there are pitfalls, but then this allows us to do repeated measurements without having to catheterize the patient. So I think centers can evolve an operator or a person who would do these regularly and who also does the cath, so that he gets an idea of how to compare these values and actually understand. So I think an individual or a person might be designated, or he can develop the expertise to do that. We may not have interoperability will be very much high in an echocardiography, but all the values that we can determine on the right heart cath, we can determine in the echo as of now. So with this, I would like to conclude that the right heart cath continues to get, it's a very important tool and a very reliable tool to assess hemodynamics. Pitfalls should be understood. A lot of reports I have seen, they don't report that sort of accurate. And people should be aware of what the effect of, even if you don't zero properly, you may land up with the patient may be put into a different category patient. And the PA pressure seems to be an overall important marker. Of course, in idiopathic pulmonary artery hypertension, it is a disease itself. But then even in other cases like cor pulmonale, like ILD and all, the PA pressure estimation is an important parameter. So far as the listing is concerned or post-transplant outcomes are concerned. So echo, like I said, is an important thing. And MRI also would play an important role because cardiac output, filling pressures, regurgitant fractions, all these can be very reliably be measured with MRI these days. Thank you, sir.
Yeah, thank you, Aditya. I had an extensive discussion there about right heart cath. So see, we know, as far as these arguments are concerned, we are really interested in your pulmonary artery systolic pressure value, because intra-op, we tend to electively go on ECMO if the PA pressures are too high. So we find that the moment we go on one lung ventilations, saturations drop, your hemodynamics become bad. So we don't really want people to crash and then go on ECMO. We go on a elective ECMO. So anyone where your cath report will be showing a high PVR or pulmonary systolic pressures high, we would end to go on a elective ECMO. Two is coronary artery status. We rarely or uncommonly see people who have CAD2. So now, opposing you see CAD, significant CAD, and you want to do would you prefer to do a PTCA or a CABG along with the transplant? Because once we do a PTCA, we all know you are on dual antiplatelets. We have a bit of bleeding in transplant, especially if we have severe adhesions, especially if it's a bilateral bronchiectasis or some inflammatory pathology. We are on to be having severe adhesions there and a bit of a nose. So being on dual antiplatelets and doing an additional ISIS, we are looking at more bleeding, more transfusions, and more PGD. So what it would be your take on it, PTCA or concomitant CABG?
Sure, sir. So this is a very difficult situation. The thing is, I would prefer not doing an angioplasty for two reasons. Because this drug-eluting stent is a Damocles sword on the patient. Now the transplant list, what I have seen, lung transplant particular problem seems to be bleeding, which you people are quite apprehensive, and it's a significant complication in your thing. I've seen it several times. The second thing is, we don't know when this person is going to get an organ. We don't know whether we can stop the drug and wait for the transplant to occur, because these are the sort of things that may happen in crops. You may have 4 or 5 organs available, and suddenly the person may come up high in the wait list. So my approach would be that unless this is really a a critical lesion or something, some sort of a ACS kind of thing, I would not encourage to go for a PTCA. Now, I know it is a bit of an additional complexity during the time of transplant to consider a bypass graft, and you would be distracted with that sort of thing. Again, you have to heparinize, and some issues might come up. But I would still stay away from angioplasty, because DES, the behavior of the drug-eluting stent is still not very clear. In the sense that if we discontinue the dual antiplatelet strategy in anticipation of a transplant, we may land up with a cardiac problem. So that is my take, sir, on this.
So supposing we see somebody who already has had a PTCA. Yeah. He is like 1 month PTCA, and he comes to us. We need to do an evaluation. We are in the dilemma where we can safely, relatively safely stop your AXR plus ecospin to only ecospin. Is there any guideline? Is it 1 month or 3 months or a year?
So, sir, the thing is, it's like this. The latest generation drug-eluting stents they feel that even after 3 months, we can discontinue the dual antiplatelet strategy. That is number one. But having said that, the complexity of angioplasty is also a key word, because these days stents are so widely rampantly used. Most of them are off-label sort of things. You put a stent in the LMCA or proximal LAD and a bifurcation, kissing, this, that. So every stenting, I would not treat it in the same way. The complexity of stenting also would affect the stent thrombosis risk or those sort of things. A plain stent with a good expanded stent, I don't mind, stopping antiplatelet after 3 months. That is number one. One thing I would want you to consider sometimes is the cangrelor bridging therapy. Cangrelor is a very short-acting antiplatelet, which has got a half-life of 3 to 6 seconds, and you can continue the antiplatelet till round about the time of your surgery also. Okay. In case we are discontinuing, and just about that time you can discontinue. You can do your surgery. The effect will be worn off in 1 or 2 hours, and then you can restart whenever you are comfortable. So the bridging is something that I'm considering in some of the, I mean, of course, transplant cases I'm not come across so far, but in urology I've seen this problem, because there's the most typical nightmare for a cardiologist is somebody goes for a prostate surgery, and then we know that some ischemia test comes positive. We do angio. He has got severe disease. We put a stent. Now we are stuck. Okay. Now the thing is, the urine is something that we keep dribbling, and the hematuria won't stop. So this is a nightmare scenario. So some of these patients I have suggested to go for the cangrelor bridging therapy. So that is one thing I can suggest. But otherwise, to have a major cardiac problem during the lung transplant would be a disaster.
Okay. And another query I had, we have a few patients on ECMO preoperatively. So there, how challenging is it to do a heart cath, or I wanted to do an echo right heart cath, shifting with all that ECMO apparatus. ECMO flows there and you're doing your cath.
Correct, sir. Correct. So I here in this regard, sir, it's a very interesting question, because all our calculations of cardiac output and all are based upon those arteriovenous difference of oxygen, which of course with an ECMO will not be able to make any conclusion. So I don't think cardiac output assessment with ECMO and we do right heart cath is not going to work. The only logical or reasonable logic of doing a cath on ECMO is to know the coronary artery status. Again, some centers, I believe, they are following a system where if the risk factors are not there, or they are not very they are going for a inducible ischemia like a DSC or something. They are not even going for angiogram also. Only there are some centers they are avoiding entirely angio also. They're going like a DSC kind of thing, and they're managing with that. The third thing is obviously the pressure measurements and all will be very much affected when the person is on ECMO. See, one of the other concerns for you would be what would be the LV filling pressure, because is there any diastolic dysfunction, or is there any? Most of your patients would be on VV ECMO actually. Yeah, most of them would be on VV ECMO. So our patients would be on VA ECMO, cardiac patients, those sort of. So we have a different way of looking at it. So I think there would be certainly an impact on the estimation of filling pressures of the LV also if somebody is on ECMO. So I have a reservation in only apart from coronary anatomy. I don't see any great logic in doing a right heart study in this patient.
So would you prefer to do an and bypass right heart cath in them in a patient who is on ECMO?
You mean to say this one, sir?
Supposing somebody is on a ECMO, would you prefer to do only an echo in them and not a?
Yeah. So we are doing we are doing catheterization for two reasons, no, sir. One is the coronary thing. The other is the filling pressures. Of course, like I said, patients on ECMO, I really can't find a very strong reason to actually do a right heart cath. Frankly speaking, I don't. Most of the ECMO cases I'm only doing the angio, sir. That's all. Yeah.
So and now we know we are the incidence of a heart lung transplant is actually coming down. We predominantly doing bilateral lung transplant. If we see that the LV is pretty normal, the RV remodels. What could be your criteria to recommend a heart lung transplant?
This is again an interesting thing, sir, because there are two scenarios. As a cardiologist, I see Eisenmenger syndrome quite often, and the idiopathic pulmonary artery hypertension. Again, a very difficult group of patients who are very sick, young females, those sort of patients. Now the issue sometimes was somebody has RV filling, RV diastolic pressure of 20 or 25. The IVC is say 3 centimeters, and that sort of thing. I am apprehensive, or I don't know whether you just transplant the lungs and this heart is going to support the circulation post transplant. So I think sometimes you may have to bridge them with an ECMO or something. I'm not sure how this group. I think this is a very tough group of people that way, because where we don't know whether the RV has suffered some irreversible damage is one thing. But most literature seems to suggest that the RV recovers well after we have done the lung transplant. So that is one thing. The second is Eisenmenger group. Now, even in the Eisenmenger group, they say a defect which is easily amenable to correction, say an atrial septal defect or a ductus arteriosus. There you may consider doing a lung transplant along with the intracardiac repair. But the more difficult repairs, like suppose you have a ventricular septal defect or a transposition or some of those sort of things, it is suggested not to go for an extensive cardiac repair and also lung transplant, because that will add to many layers of complexity. So there probably you have to go for a heart lung transplant where complex congenital heart disease is there. And the other group where a simple congenital heart disease is there. Like recently we have assessed a Nabil patient who has an ASD with Eisenmenger. So maybe that is a kind of patient where we might take a chance with a ICR and a lung transplant.
Thank you so much. So, we'll go on to our next speaker now. So he's speaking on pre-transplant challenges prior to transplant. Vimi is our young dynamic transplant pulmonologist, who's my own colleague, and I think he will be taking us through some of the challenges that we faced in a few of our patients. Go on, Vim.
Is the screen visible, sir?
Yeah, it's okay.
Okay. So thank you, sir, for the introduction, and thank you, Yashoda, for giving us a platform to share the knowledge about the some of our work and the different pre-transplant challenges. So I'm just going to brief about different challenges that we come across in our transplant OPD. So I just listed out the major important ones. The first and foremost is nutritional issues, like either a malnutrition or an obesity, and other important entities are different gastroesophageal reflux disease, the coronary artery disease, psychosocial support. And many of them, you can see that they are either malnourished with, when we do a DEXA scan, they are having a almost the T-score is almost 2.5 -3, and they are in a severe osteoporosis. And those who have a prior renal issues, they are most likely to have a renal failure even after transplant. So this is in short about different pre-transplant challenges that we come across. Now, speaking about nutritional management, we know that most of them come to our OPD, especially transplant, either very much malnourished or they are overweight. Somebody who's coming with a BMI of 20 to 25 to a transplant OPD will be little difficult in the current scenario, because most of them what we are dealing is with an interstitial lung disease or bilateral bronchiectasis. Now, when we look at the guideline as per the ISHLT, the BMI of less than 16 and more than 35 is a relative contraindication. Now, this is a major concern, especially with the bilateral bronchiectasis. So we have seen many patients with a bilateral bronchiectasis coming with a BMI of 9 to a BMI of even 18 to 19. Now, it's a very difficult group that is difficult to, especially helping the nutritional management. So what we usually do is that we take the help of dietitian about different approaches that they can help with. And we also know that when they come in the low BMI or higher BMI group, there is an increased risk of post-transplant mortality. Now, there are few cases that we have even tried for rail feeding or a peg feeding in case of them not improving after the maximum diet supplements. Now, other most common problem is osteoporosis. This is very important, especially in COPD and ILD patients, especially when they are on prolonged steroids for their primary treatment or for their exacerbation. When we do a DEXA scan, we see the T-score and we'll be thinking, how come they are having this much low T-score? So that is very important, so that we can even do supplement them with a calcium, and we give them like, for example, many other agents to prevent the bone resorption. So DEXA scan, as we know, it's a very important in our workup, so that we know how much is the degree of osteoporosis and do we really need to supplement. Now, other common entity that we come across in our pre-transplant workup is most of them who are having a normal renal function prior to transplant. Most of them after the transplant, we can see that they are going for a acute renal failure. Now, there are many reasons for it. Now, I'll be just listing about few reasons. So, when anybody is having a higher baseline creatinine, or when they have a pre-existing renal impairment, they have a greater risk of rapid renal function loss. Now, those who have a less renal reserve, they are unlikely to tolerate the different hemodynamic variation and the renal toxicity, especially after transplant, because of different immunosuppression, and they are more prone for AK. Now, there are many factors right from pre-operative, intraoperative, and post-operative. Now, in a pre-operative, one of the most important thing is the higher baseline creatinine when they are on a mechanical ventilation and or they are on an ECMO. So different hemodynamic disturbance, as we have as I pointed out, they are more prone for a acute renal failure. Now, during an intraoperative factors, the first and foremost important is a blood loss, different blood transfusion, and the hypoxic injury. So these are the three most important intraoperative factors. And other post-operative is the different calcineurin inhibitor, which the patients will be permanently on after transplant, and prolonged ECMO and sepsis, etc. So this, in short, is a different outlook how we should approach a renal failure from a transplant point. Now, as Dr. Aditya sir has already said, we have seen that there is a high prevalence of CAD seen in lung transplant recipients. So most of our patients, when they come after a CAT study and catheterization, they'll have either a minimal CAD or a CAD which require grafting, etc. So CAD was not associated with a worse survival for patient undergoing PTCA with stent placement prior to transplant, or a CABG at the time of transplant. Now, as we know that patients who are with an underlying coronary artery disease, they are for different. They're most prone for coronary artery disease because of many agents. One is they are on immunosuppressants, and different immunosuppressants has as a side effect of hyperlipidemia, etc. And most of them after transplant, if they are not adequately on a good follow-up, they'll be either less immobile, and that also predisposed to a coronary artery disease. And as we know, is that coronary artery disease is a marker for systemic atherosclerosis. So a patient with a CAD should be evaluated for other peripheral vascular disease like cerebrovascular and other peripheral vascular diseases, etc. This plays a very important role during transplant and after transplant, because especially this takes a major role, especially in connective tissue disease patient, where their peripheral arteries are compromised, they have peripheral cyanosis, and this is of utmost importance to be taken care. Another most important thing, and this is the image of one of our patient who has done this procedure pre-transplant. Now, why this gastroesophageal reflux is very important while we're speaking about pre-transplant workup. So, as you know that GRD is associated with risk of rejection, pulmonary infection, and earlier development of clot. Now, the right side picture is one of our patients who has done a procedure called as anti-reflex microscopic ablation or ARMA. So this patient was primarily diagnosed with scleroderma, and when we have done a manometry, her peristalsis was almost 90%. There was the failed peristalsis, and there is no hiatus hernia. So this is a patient whom we know that she's got a large esophagus, and there is almost 90% failed peristalsis. So we have done a procedure like what I said in the mention called ARMA, so that we ablate the lower esophageal junction, so that it reduces the size and thereby preventing the micro aspiration. It plays evaluating for gastroesophageal reflex, especially with the underlying connective tissue background, it's of very importance. Now, I'm not going to tell extensively about pre-transplant sensitization. However, the three most important things that we should be doing in a pre-transplant, one is a HLA typing, and everybody might have heard about panel reactive antibody. So it measures the probability of a positive cross-match, so which we know by HLA antibody identification, and the different cross-matching tests, that is lymphocytotoxicity and CDC, which is of utmost importance. And I think we also had a personal experience where we have seen a patients with antibody mediated rejection after transplants. So it is of utmost important that we look at the HLA from an immunology point of view, especially prior to transplant, so that we know how well the patient do after transplant, especially with regards to cellular or antibody mediated rejection. So this is one of the CDC report. You can see that at the lowermost part where you can see the cell lysis of the cell, and which shows about a cross-match. So there are many other pre-transplant challenges. So we have many patients that is coming with recurrent infections, bloodstream infection, etc., which has to be taken care, and many people will require multiple admission. So we have to stress about the role of vaccination. And other foremost important is a psychosocial support. So most of them will be very depressed, and especially when they are on oxygen, we have to really counsel them, support them from a transplant team, and the motivation has to be given to the caretaker. Another most important thing that we see is that once they are listed for transplant, they stop the medication. So having compliance, talking to them at serial intervals about how is their compliance is of utmost importance. And other most important thing is that when they are away from home, they are living near a transplant center, leaving the family and other supporting people from hometown and coming near a transplant center. So there are these are the different pre-transplant challenges that is to be utmost be taken care, especially while considering for a transplant. So a detailed history from a transplant point of view is very important, and always try to optimize the maximum in the pre-transplant period, which determines the transplant success. And a repetitive and regular visit to a transplant center is of utmost importance. So these are transplant team. Thank you, sir.
Yeah, thank you, Vimi. Now, I had 2 or 3 queries here. One is, we all know that the nutrition and physiotherapy preoperatively are really, determine your transplant access to a large extent. Now, we see patients complaining that even though they eat a lot, they are really, eating a lot, but they are not gaining weight. And maybe either their family members are a bit sad that even though they are being fed a lot, and I think it's happening there. So how did you handle such a problem?
So first and foremost is that we look at what the primary etiology. So especially with cystic fibrosis, non-cystic fibrosis bronchiectasis, there is a great role of the protein supplementation and the different dietary pattern. So that is one of the things. One is the look at the etiology. Second thing is that we look at what are the muscle involvement, or we look at what are the ways we can try to improve the muscle mass. So most of them, what is happening is they will be having a decreased muscle mass, and they'll have decreased supplementation. So we usually try to give different protein supplements in whatever way they like, and make sure we improve the rehabilitation point of view, so that to strengthen the muscle mass. So these two are the important things. However, most of the time what we see is that improve even after these two parameters control. So then we look at the different aspects of rapid feeding or a peg feeding in case of other advanced nutritional loss.
And what about physiotherapy? So somebody who is on 4 liters for 8 liters, they say and they start doing the physiotherapy, they start dropping. So should go up on oxygen? How much exercise should they do? When should they stop?
So ideally, sir, this is a usual misconception that when they are on oxygen, everybody thinks that physiotherapy should not be done. So first of the main important thing is that we have to train them that there are many methods that we can improvise where we can train this patient with a serial physiotherapy. So if you ask me, ideally, we usually do a cardiopulmonary exercise testing, and we measure the load, and then we give the serial weights in a physiotherapy. However, if you don't have this cardiopulmonary exercise testing, we start with a serial small weight load. We first of all condition them and make sure that we improve their upper and lower limb muscle mass and condition them. And I think that's the maximum way. But other major important thing is that they don't usually come to a rehab center for a regular session, as compared to abroad, where they come thrice or 4 times a week for a regular physiotherapy session. Here, what usually happens is the rehab person go to their home, train them, and it's like when we see of them after 2 weeks, most of the days I don't do physiotherapy because I'm worried. So this is a different stigma that we come across, which we have to regularly motivate them to make sure that they come out of that.
Dr. Pradeep, are you there? Yes. Hi. See, do you recommend a pre-op ventilation perfusion scan to know your split lung function?
It is not routinely recommended to do. We routinely do a CT pulmonary angio if we have a doubt, but it is totally a surgeon's perspective whether which lung to operate first based on ventilation and perfusion. But according to a medical management, I don't think so. It is routinely needed.
So in our view would be, if I'm not putting somebody on an
ECMO, yes.
ECMO, I surely like to know which I to operate on first. So I think if you are going to do a non-CPB PA pressure stability, okay. I would surely like to have a BQ scan to know whether to do on the right first or left first. So I think we had a excellent session today.
Dr. Gopal had raised some 3 questions, sir. Could we just address them? They're in the chat box, sir.
Yes. So can vasoreactive testing be done with milrinone?
No, sir. Actually, so far as I know, the drugs that have been tested were ipoprostenol, adenosine, and iloprost. These have been used for vasoreactivity testing. I have not seen any report of this one, sir. Oxygen, of course, we were using earlier, but these days we don't really use it much. Nitric oxide, oxygen, adenosine, iloprost, and ipoprostenol. These are the things that have been used for vasoreactivity testing. So far as I am not mildew.
Yeah, and the second the third question to I think it is for you. How do you quantitatively assess an increase in the muscle mass apart from weight gain? I think Vimi can
Yes,
answer.
sir. So, quantitatively assessing the muscle mass is very difficult. So, what we do is that we try to look for different muscle power by different ways of cardiopulmonary exercise testing. Then we see the VO2 max, and that is one way that we can at least quantitatively tell about how is the conditioning of the muscle. But if you ask me, the individual muscle to quantitatively tell is difficult. So I think only by a CPET we can have at least a objective measurement to that point of view.
Okay, and the last question, I think I'll take it. Will a lung transplant candidate really be fit for us? So whenever we go on to do a lung transplant, of course we want on the normal heart. But if we see significant CAD, we have to address that. So we prefer to do a clamshell and go on to a beating heart CBG, revascularize the heart, and then go ahead to do a transplant. So if we have problems like arrhythmias, BT, BF, AF, and all intra-transplant, it becomes an issue. We have forced to go on to BA ECMO. So we would always prefer a revascularized heart and compared to an unvascularized one. But of course, transplant to being a stressful procedure for the patient, where and you add a CABG onto that, the risks are a bit more higher than normal. But if we have an opportunity, surely we will do a CABG along with a transplant. So I think we are running out of time now. So I'd like to thank all our speakers, all the audience who has been patient enough to listen to these talks. And we'll be seeing everyone after 2 weeks for our next program. Thank you so much.
Thank you, sir.
Thank you, sir.
Good night, sir. Good night.